Throughout this conference thus far, we've heard the repeated theme that we need to be bold and inventive. We've also heard that there will be challenges along the way, and there are sure to be setbacks and struggles going forward as we look towards driving smoking rates lower. Kylie and Libby and I were invited to coordinate this session on behalf of the next generation of leaders in tobacco control. So the three of us came up with, I think, about 3 brave ideas, one very obvious one, and then we also thought that it was important to consider the priority populations, and I think it's important to think about not only the youth coming up, but also those priority populations that we've been talking about over the next few days if we're going to achieve a nicotine-free 2035. So to present and discuss these ideas with you today, we've roped in a few friends, colleagues, and even some innocent bystanders visiting from the US. So without further ado, we'll start by setting the scene. And to do so, I'd like to invite Jennifer Gershik from the epidemiology branch at the Department of Health, Western Australia, to present Setting the Scene, data to support the ideas for tobacco control.
So when we were asked to provide projections for this session, which is what we're doing, there was much wringing of hands, gnashing of teeth and pulling of hair in the department. And this is why. That's the kind of disclaimer that normally accompanies projections. That one comes from the AIHW. You don't need to read it. Niels is going to summarise it for us. So projections are the epidemiological equivalent of guessing. We're trying to predict the future on the assumption that nothing except your variable of interest is going to change. So the data that I'm presenting is projections out to 2025, and I'm not going to go into the details of how the projections were done, but just be aware there are a number of different methods. I've used several different ones here. They're all based on assumptions. They all have limitations. You have been warned. In addition, although I recognise that the scope of this conference is oceanic, the department really only has access to WA data, so that'll be the bulk of this presentation. These 2 figures show what the future of smoking in WA might look like. So this data comes from a health and wellbeing survey that the department has run since 2002, and it asks adults aged over 18 about smoking. So you can see there's been declines since 2002 to 2014 in the rates of smoking. And projections show that this is likely to continue. So the 13% of adults who reported smoking in 2014 will decline to about 8% in 2025. But you can see in the bottom figure that this still represents about 200,000 people. The limitations of this data is that it's a self-report telephone survey, and we recognise that this won't capture everyone, and in particular high-risk populations. However, it's the only statewide continuous survey on smoking behaviours, and it has excellent response rates, continually above 90%, which I know would be the envy of many other surveys. So the next 3 slides present some death data on tobacco-related deaths. This first figure is for lung cancer deaths, and it shows historical trends with some projections. So for males, you can see that there's been a dramatic decrease in the long-term death rate for lung cancer, which we attribute predominantly to the decreasing prevalence of smoking. This trend's likely to continue with projections, and so we're looking at a rate of about 32 deaths per 100,000 population for males in 2025. For females, the death rate doesn't yet show indications of a decline, and that's probably due to the lag between tobacco exposure and the development of the disease. The projections seem to show that the death rate for women may be increasing, but I suspect that's an artefact of the projection method, because we are expecting it to plateau and then eventually decline. The other striking feature of this graph is that the historical gap between men and women in lung cancer mortality is closing and looks like it'll continue to narrow into the future. The limitation of this figure, though, is that it includes all deaths, not just those related to tobacco. And while this is unlikely to have a big effect on lung cancer deaths, for other conditions such as ischemic heart disease, for which there are a number of related causes, it's likely to be a bigger limitation. And so this figure is the death rates for ischemic heart disease, and then, as you can see, for males and females, the trend historically has been a decline, and projections show this continuing into the future. And so we're looking at a death rate of about 50 per 100,000 for men in 2025, and something a little less than half of that for women. And these are deaths from chronic obstructive pulmonary disease in WA. So again, the long-term death rate for males, you're seeing a decline since the late 60s, although this does look like it's plateauing in the mid-2000s. For women, again, you have an increasing trend, but it also seems to have stabilised in the mid-2000s. Projections suggest that both male and female mortality will remain more or less stable into the future. So to summarise these past 3 slides, trends seem to be heading in the right direction. For males, they're still decreasing. For females, increasing trends appear to be stabilising. What these death data don't do, though, is tell us the proportion of deaths that are attributable to tobacco. We do, however, have some data that's smoking specific. So this is burden of disease data for the Oceania region from the Global Burden of Disease. So burden of disease is a modelling technique. It basically combines a number of different data sources. It looks at both fatal and non-fatal outcomes, and its main purpose is to get a single measure of the impact of a disease on a community. It enables us to do comparisons. The most common burden of disease measure is something called a disability adjusted life year. So there's really 2 things that you need to take away from this table. Tobacco was the second biggest cause of deaths in Australia, New Zealand and Oceania in 1990, which is the top figure. And 23 years later, it remains the second biggest cause of deaths for Australia and New Zealand. And while it does appear to have decreased for Oceania, which is good news, and this figure really highlights the importance of ongoing tobacco control across the region. So just for my last slide, this is a very brief snapshot of the kinds of data that we have and the kinds of analysis that we can do at the EPI branch. We have access to an enormous range of data, and we regularly advise and collaborate with a whole range of people. So if you do have questions that you think we can help with, please ask. Thanks.
Thanks, Jen. So now we're going to go through a series of 4 presentations on some of these ideas. And to start it off is Kylie Lindorf from Cancer Council Victoria to talk about the tobacco retail environment.
Thanks, Scott. Most of what I'm going to present have been written about previously, so none of them are completely new. In particular, I'd like to acknowledge the work of Cynthia Callard, a colleague from Physicians for a Smoke-Free Canada. Demand and supply side measures. In Australia and in our region, we've done pretty well at demand measures which aim to influence the smoker to reduce demand. And all of those measures there are fairly familiar to us, and most of them we've been really quite successful in implementing. There's still a way to go, but we've done pretty well. Supply side measures influence the supplier to reduce the availability of tobacco, and really there's not much we can talk about there. We've got some illicit trade measures in place. There's some bans on certain products, but very few, and sales to minors bans. But we really haven't done a lot in this space, and there's certainly a lot of room to move there. So our demand reduction measures in Australia and indeed the region have served us pretty well. And I'm certainly not saying that we're done there. We absolutely need to continue to use them, to upgrade and monitor them. We need social marketing campaigns funded to the right levels that we know have an effect. We're going to need more tax increases and price controls, look at plain packaging and graphic health warnings, keep them up to date, and absolutely, as we've heard, keep things like Quitline available and make sure we have even better targeted cessation programs. We still need all of those things, but I don't think we can address this so-called end game or wherever we want to get to without addressing supply. And really, we know that the tobacco industry are unfortunately not just going to pack their bags and go home as much as we'd like them to do that. It'd be nice to give us signs like this and say that they're off and going. Not going to happen. They'd probably look a little bit angrier. They'd probably look a little bit like that if they were heading home. And that'd be all right because we could spend our excess social marketing money on T-shirts that said that. But that's kind of my little dream. That's not going to happen anytime soon. So, what are these supply side measures? So what I wanted to do today is just put some ideas out there. I'm not saying these are the ones we need to use, but I think we need to start a dialogue on these types of issues and see what we can come up with. At the moment in Australia, we don't have many. 5 out of 8 states or territories have got some sort of retailer licensing. However, they were really brought in to help with communicating with retailers, enforce sales to minors, and to raise a little bit of revenue to fund enforcement. But none of them were introduced with the explicit aim of reducing the number of retailers or controlling who can sell, when, where, and what. And it's worthwhile remembering that, there are other goods and services that are out there that actually do have controls on their supply. So pharmacies, you have to be qualified, you have to be licensed, there's limits on the number and location, you have to provide evidence about why you want to open a pharmacy in a particular location, high cost to buy in, and there's strict monitoring of sales and compliance in terms of the business you undertake there. Another one we're all familiar with is, the taxi industry. In Victoria, you have to be an accredited operator. You have to pass a knowledge test, believe it or not. There's a really high entry cost. There's zoning of operations. So there's different rules about operation costs and numbers in different zones of Melbourne. And again, a highly regulated industry. This one might not be the best public health example, but one we're probably more familiar with is, there are really tight restrictions around alcohol outlets. There are the zoning and location issues that are taken into account, licence conditions such as opening hours and staff training. Councils and community are consulted and can object, and there's monitoring and enforcement. So these types of controls are out there for different industries, but not unfortunately for the tobacco retail market at the moment. So I've got 4 options I just wanted to put out there. The first one is what I've called strategic licensing. So not just licensing for those reasons I said before, but let's get strategic about it. We could put licensing in and look at reducing the number of retailers or reducing the hours that they could sell products. We could look at restricting the location of retailers. Are they allowed around schools? Are they allowed in education campuses? Restricting the type of premise that could sell tobacco. Maybe it could be restricted to only those in which adults are allowed to enter, such as bottle shops. We could restrict the density of retailers, less in low SES areas or less where we know we have high smoking rates, and even restrict the amount of tobacco that could be supplied through different retail outlets or even purchased. What about, we often think of retailers as the bad guys, and a lot of times they are, particularly with sales to minors, but reality, they're members of the community like we are. Most of them probably don't smoke, and I'm sure many of them don't actually like or feel comfortable selling tobacco. So rather than sort of treating them as the bad guys, what about providing positive incentives to them to try and convince them to stop selling tobacco products? What if we gave them financial incentives? They could be one-off payments to get out of the business, reduce council rates, reduce business registration fees. There's a whole lot of things there that could be financial inducements. What about if we link them up with companies that provide products that have a better turnover or higher profit margins than tobacco? Everyone has some sort of electronic device, phone, iPad or whatever. What about linking them up with companies that supply the data and the recharge cards for that? What about giving them a coffee machine and they can sell coffees because, Australia's obsession with coffee is not going anywhere anytime soon? What about if we helped promote individual businesses who cease to sell through something like healthy community campaigns? We make a big deal of the retailer on the corner, the milk bar, who decides to stop, and we give them promotion that they've decided to help the health of their community by stopping to sell. Some ideas out there. This is where I do go a bit radical. All right, what about if government controlled everything to do with the retail sector? So we're talking about a state retail monopoly, and by state I mean not states and territories, but the government. So government could control pretty much everything: the number of licences, the locations, the opening hours, who can apply for a licence, what other goods and services they can provide, the pricing of tobacco, etc., etc. And while this might seem unrealistic, this is actually how les buralistes, where's Denis Chinois, probably, excuse my French, are structured in France. They were originally implemented under a business or a profit model, and there's obviously ongoing issues in France with that type of model, but it could be implemented under a public health model. And at the moment in France, the government controls the number, the location, other goods and services that can be provided by these outlets. There's mandatory training. You can't operate more than one outlet. This is where it gets very interesting. Sales data is reported monthly and available to the public. You can log onto a website and get sales data for these retail outlets. They also have to nominate a minimum price each month and not sell below that. So these are just some of the things that if you've got a really strict environment or setting like that, you can control a whole range of things. The last one I wanted to look at is what if we actually restricted supply by product type? So we started looking at the types of products you could sell. Australia currently bans oral tobacco, but what if we banned any new tobacco product whatsoever? If it's got tobacco in it, you can't bring it onto the market. What if we banned any new brand, any variant or modification of existing product? We froze the market where it is, that's it, nothing new. What if we banned all flavoured tobacco, including menthol? We banned fruit-flavoured cigarettes. Let's extend that even further. We know that flavoured tobacco and filter venting increases palatability. What if we banned any recreational smoking or vaping device or similar? Nothing new can come onto the market. Ban any non-medicinal nicotine delivery systems and gradually reduce supply, then ban tobacco outright. Might seem unrealistic, but supply of tobacco is currently banned in many prisons. Different setting, I know, but we've done it in a particular setting for very good reasons. Okay, what next? There are many options for regulating the supply of tobacco products. I've touched on only a few. There are a whole lot more that we should be looking at. We need to start formulating principles for supply reduction and policy options to achieve them, and we obviously need to do a lot of research to feed into what those policy options could be. We need to think broader, bigger and braver than simply retailer licensing. I think we've been very narrow in what we've been thinking about, and let's think bigger and braver than that. And we need to start a dialogue with government, regulators and the public about this issue. This is long term. None of this is going to change overnight, but we need to start laying the groundwork now. And, remember when plain packaging seemed like an impossible task? Only a couple of conferences ago, probably not many of us would have thought that plain packaging would get up and be out there. Well, I think we really need to believe that this type of scenario is possible for tobacco retail sales in the not too distant future. And that's that we'd see these types of signs going up. Thanks, everyone.
I can just see the next Cancer Council fundraising campaign being for your $2,000 donation, you can buy out a tobacco retailer. Our next speaker probably needs no introduction. He's been on the stage a few times throughout this conference. Frank Chalupka is from the University of Illinois at Chicago to give us some ideas of how far or how high we need to go with tobacco taxes and what things we can do with different products as well.
Yeah. I was asked to talk about brave ideas for tobacco and nicotine pricing. So just a few ideas. I scratched my head trying to figure out what I would talk about with this. The one thing we know is that price increases work. I keep getting the question that, isn't there going to come a point where eventually we keep raising the price and it stops having its effect? What we see is that hasn't happened anywhere in the world yet. This is a picture from New Zealand. New Zealand, like Australia, has some of the highest taxes, highest prices in the world. They keep pushing tax and price up. Price keeps going up. Consumption keeps coming down. Prevalence keeps coming down. And some of the work that we've been doing actually suggests that, if anything, what's happening is that as tax and price get higher, we're starting to see bigger effects for the same price increase. So the work that we've been doing in the U.S., we're taking advantage of the fact that we have seen very different changes in taxes and prices across states. And what we're finding is that states that have high taxes and prices to begin with, if they raise their price by 10%, they're seeing about double the effects of states that are at the average price levels. So I told you yesterday, 10% increase in price gets about a 4% reduction in consumption. What we're seeing is that, if you're at a price level that's much higher, you may be getting 8% reductions in consumption as a result of that higher price increase. And then the other thing that we're seeing is that the way that the tax and price increases get phased in seems to also have an impact on how it affects consumption. Here what we're seeing is that the bigger increases that happen less frequently end up having a bigger effect. So I always thought that the sort of things that New Zealand was doing, that Australia was doing with these annual extra normal price increases would be the way to go. But now I'm starting to think that maybe we want to think about not increasing price every year, but maybe we talk about a 25 or a 50% increase in price every few years rather than 10% a year, 12.5% a year increases in taxes. So I think a couple of reasons for that. One is just that it's a lot harder for the industry to swallow and to sort of gradually pass it on to consumers in a way that minimizes its impact. And then the other part is it just comes as much more of a shock to smokers. It's going to be something that's going to be a lot harder to adjust to. And then all the extra debate that goes around that big increase tends to have a big impact. Big increases, less frequent increases are the way to go. So this session was talking about nicotine and trying to go towards a nicotine-free Oceania. So we've been doing a lot of work over the years also looking at the demand for other nicotine products. So we did a number of studies that showed that nicotine replacement products were very sensitive to price. If their prices came down, people were going to be more likely to use them. We also saw that they were substitutes for tobacco. If you raise cigarette prices, people would switch to nicotine replacement products. You get some people trying to quit. But then we started looking at the most recent data, and this one looks like the basic laws of economics don't apply anymore. Prices have been coming down, consumption's been coming down, sales have been coming down. For patches, we see pretty much the same basic pattern for gum, which suggests that something else is going on. And in the US, what it is it's the rapid rise in electronic nicotine delivery systems. So e-cigarettes have become the go-to source for nicotine. People aren't using patch and gum as much anymore. And the e-cigarette business has probably had its biggest impact, not so much on the cigarette markets at this point, but much more on the pharmaceutical nicotine markets. We have been looking at trying to understand how price affects e-cigarette sales in the US, e-cigarette use, who's using it, how they're using it in combination with other products. And we see really big price effects when it comes to e-cigarettes. So we published the first study on this last year, where we estimated that if we raise prices for e-cigarettes by 10%, we'd get about a 12% reduction in the disposable e-cigarette sales, about 19% for reusable e-cigarettes. But we weren't finding consistent effects with cigarette prices. I thought it would be pretty obvious. I thought if you raised cigarette prices, people would go to e-cigarettes. We weren't seeing so much of that in the data that we were looking at there. And I think in part because we were capturing this market early on, so these products were just coming to market in the data that we were looking at. Not surprisingly, they were showing up in places where there were a lot of smokers to begin with, which was the places where cigarette taxes, among other things, were very low to start with. So I think that helps explain part of it. We've been looking at the same thing in the EU. We're seeing similar effects. We have a more aggregated version of sales and prices here. But again, we're seeing that the demand for these products is very strongly associated with price, much more affected by price than cigarettes. And again, we start to see some association with cigarette prices suggesting that there's at least some substitution going on. We have a paper that's under review right now looking at a survey that we've been doing, an online survey where we're asking people about their e-cigarette use. We have the markets that they live in. We can then associate prices with those markets, control for a lot of other factors. And here again, we're seeing some evidence that e-cigarettes use, the decision to use, is going to be associated with price. What it looks like here is that there's a lot of experimentation going on with the disposable e-cigarettes in particular, and the likelihood of anybody using those is really strongly related to price. But when it comes to more regular use, when people transition away from the disposable products, the rechargeable products, move into the open systems, the tank systems, then we don't seem to see the same price effects, but we don't have prices for those, which is part of the problem, so we can't really measure that price effect. And then the other thing we have in the works is some work with surveys of youth in the US, where we're seeing, to me, actually unbelievably large price effects, so we want to go back and do some more work with this, but we're seeing kids, again, compared to what we see with the overall market data, kids seem to be very, very responsive to e-cigarette prices. So we're in the process of updating that analysis to include the most recent data. But again, it seems, it's price that really does drive the demand for all these products, all nicotine products. So not just tobacco products, but it's also driving NRT products. It's also driving e-cigarettes. So what are my big ideas? And I'm sure these will be non-controversial. One is to open up the market to these other nicotine delivery systems, electronic nicotine delivery systems, and to really try to set up our policies, our tax policies in particular, in a way that tries to move people away from the most harmful products, the combusted tobacco products, over to the other cleaner forms of nicotine delivery. If we were to go ahead and do this, I would recommend that you don't do what we've been doing in the US, that you really make sure that these products are highly regulated, that they're subject to smoke-free policies, that you're not allowed to aggressively market them like we see in the US, that kids can't buy them. We have a number of states in the US where kids can buy e-cigarettes no matter what age they are. They don't have to be 18. At the same time as we do this, we put in place big tax increases for combustible tobacco products in particular, and we tax the electronic products but at a lower rate in a way that gives them a price advantage. So we tax them high enough to discourage kids from taking them up. We tax the combustible products at a very high rate to keep kids from taking those up, to get smokers to try to quit. And for the smokers that have the hardest time quitting, they still have these other products available at a preferential price that they could switch to. So I think in the short run, the idea is to try to move people away from those harmful forms of nicotine to cleaner forms of nicotine. And then if and when we succeed in doing that, then we start to think about how to then get them off nicotine entirely. And that's where we start to think then about taxing based on nicotine content down the road, so 10, 15, 20 years from now. And then as always, the revenues that come from these need to be used to support everything else that we're doing. So I'm sure everybody agrees with all those ideas. And there's all the information as usual. Thanks.
Thanks, Frank. Next is Sarah White, Director of Quit Victoria, and she has promised me that she will challenge us and try to blow our minds a bit.
Thanks. So this was an invitation that was impossible to refuse, and I know because I tried. I've been in tobacco control for less than 12 months, so when I was asked to deliver a brief on brave new systems, I was not impressed. And in fact, what I said was, well, can I talk about obvious new systems? Because there's been plenty of great ideas here about systems that we could try and influence. And then I went to, well, how about instead of obvious new systems, I'd be challenged, how about we exploit every single opportunity? So I know leverage is much nicer, but I'm deliberately going for exploit. Why would we even worry about systems? Look, again, pretty obvious. Every single touch point should be an opportunity for us to collect data. That's actually more for us than for the people we're trying to help. But we'll be able to get data if we channel this idea on micro groups, on little populations in communities. We can get a single GP to tell us about the smoking community immediately around them. We want to motivate and support those quit attempts at every single contact that a smoker has with any system. So this is not just, this is creating quit-friendly environments, not just smoke-free policies, but having staff members who are able to empower and motivate and support quit attempts all the way through, multiple bites of the apple when it comes to getting people to quit. We could get creative but not evil. Not evil, creative. What if we favoured non-smoking status? If we looked at our systems and said, where are the opportunities to really to pay it forward to those people who have made the effort to quit, who've gone through that challenge of staying smoke-free, or we could incentivise quit attempts. We should be looking at all of these systems. So none of these are solutions, guys. This is just to try and get some creative juices happening. So if we've got more current smokers or more former smokers in Australia, why don't we try and reward them? System. So I could have sat here for 45 minutes and gone through every single system and every single opportunity, and we've heard, again, great ideas here about what we can do. Health system, maternity system, community social system. I will have left systems off here that we could exploit. And I came down to two key types when I was plotting all of these out. We have a system, I think this is what we usually think of when we think of systems. It's those planned prolonged contacts. It's someone going into the machine, getting churned around a little bit, touched occasionally, and at some point they come out the other end. Very easy to plot our way through those. But what we might not have thought is that there's other opportunities that are really just opportunistic. And these are not people perhaps going into a system, but they're touch points. They might be commercial touch points that we could get into. So I came down to these two key systems. The first one is I think probably the one that we've talked most about. So we could plot a client pathway through this system and say, well, where can we reach them? Exactly what policy lever could we put in place to collect data, or what could we compel on our funding priorities, all those sorts of things. And clinical systems are the obvious sort of example of that. So imagine that 2025, 2035, smoking is recorded at every single visit. Health practitioners are incentivised to refer patients to cessation services, or they could be incentivised to move people along the progression, right? You've tried Quitline, we've done the brief intervention, you've tried Quitline, now we're going to incentivise to move you on to varenicline or something like that. So we can plot out the pathway and get really quite forensic about finding the opportunities in there. Moving on, I guess, from the primary, we could go into clinical, sort of secondary, tertiary, some acute. We probably wouldn't want to get some people in some situations, but we could have planned admissions trigger some information that's sent out. It's triggering free NRT. It's triggering calls to the quit line. We could get then cessation treatment offered for every single person who's discharged. And a lot of these patients obviously might move on to other systems, but they'll get that same consistent message all the way through. Now, this is where I could not get creative, I got evil again. What if you had private health insurance for smokers? What if you had a surgery surcharge for smokers? But if you tried, you got that waived. Now, I'm not suggesting this is the way we should go. This is really just ideas for people to go, oh, we couldn't do that, but we could do something else. But the other sort of opportunity was really around what sprung to mind, these organisations we might not think about traditionally. So if we could map points, empower people to help and enable people to be referred on to cessation. So I got to this by thinking about a Friends organisation. It's an NGO, and what it does is provide independent legal assistance and financial counselling for people who are really struggling, mostly with utility companies. So there are a lot of people out there who are struggling to pay their power bills. They're getting financial counselling from this group. And I said to her, well, what about smoking? You talk about the cost of cigarettes. And there's lots of organisations like this. So what if we made sure that we actually went into all sorts of organisations that did financial counselling or maybe social exclusion, any opportunity to start talking about things that also impacted by wealth, not just health. We could ascertain cigarette spend. You could have a lovely counsellor on, mybudget.com, sort of say, well, okay, we've talked about your immediate issues around meeting the mortgage repayments. Tell me, how much do you spend on cigarettes? How about I give you some information about that? How about, in fact, we've got a special deal happening with Quitline right now. I can transfer you straight through. So there's lots of opportunities, if you might guess my background is comms, lots of marketing comms opportunities in there that we could exploit. Now, this NGO friend of mine, when I said to her, well, cost of cigarettes must be pretty big, and she said, well, actually it is, but I don't think we go there. I said, go there? That's kind of strange words, aren't they? And she said, yeah, why wouldn't we go there? This is actually a huge cost for people that we work with, but we don't go there. I wanted to jump on my soapbox for a moment around messaging. I've warned Scott already. If we want to change systems, we have to remove the squeamishness. And it came up even in the mental health. I don't think it's my role to talk to people about their smoking because I'm dealing with their mental health. If we remove the squeamishness around what is unfortunately a bit of a negative values-based thing about talking about smoking or being a smoker, we can actually empower people that really have nothing to do with helping people get healthier by stopping smoking to start having the conversation. So talk about, how much do cigarettes cost you rather than do you smoke? So I think that what we could be doing is looking at all of these opportunities and then supplying the tools that all of these different sectors need, whether they're private, public, social service, community service, health service. There are people out there who can help us advance our cause. So I'd like to see every single time someone touches any sort of system or service, they're offered advice and some assistance. So very quickly finishing up by saying, think creative, don't be evil, and exploit every opportunity. Thanks.
Our final speaker today is Reglan Maddox from St. Michael's Hospital in Toronto to talk to us a bit about some ideas around products as well as some of the different populations. And I think especially coming back from North America, Reglan joined us last week at the end of the week on a teleconference from Canada, which was a great effort. But he's come back with some inspiration, I think, about how things could be done differently. So over to Reglan.
Thanks, Scott. I also just wanted to take a moment to sort of steal a leaf out of Tom Kalmer's presentation this morning and just acknowledge youth and young people, the future leaders of tomorrow. I just want to touch on two things. I think the calibre of people presenting at this conference over the last couple of days has been exceptional, including our young people, and for me it's been incredibly exciting to see those young people step up and present extremely well. I think secondly, and I guess I've had the opportunity to work in Canada and Australia with Aboriginal and Torres Strait Islander people, Indigenous people respectively, and one of the things that seems to be consistent is that we have very young populations. In Australia we have an Aboriginal population of 50% are under 30 and 36% under 15. So when we're talking about young people, we have an incredibly exciting opportunity to prevent tobacco uptake. When I was briefed on this presentation that I was starting to think about, if we are to think radically, maybe in 25, 30 years we won't be having an Oceania conference. Perhaps we'll be working on different challenges and maybe smoking won't be around. So I'm going to try and pull some things together, steal some ideas, and hopefully we can come up with a solution to have a smoke-free Oceania. Unfortunately, Tom and I sometimes work with similar slides, so you may have seen this one this morning. But it's basically provided us with an opportunity to reflect on how far we've come in the last 25, 30 years. It's incredibly exciting. I think if we asked some of the people that were around 25 years ago if we'd be here today talking about some of our successes and how much the landscape has changed, I'm not sure that we would have predicted where we are today. I think when we're talking about change, and I think we just heard about different systems we can tap into, Two-Spirit as they're sort of known in Canada, or LGBTQ, LMNOP, we sort of give these different terms and names to population groups that have high smoking rates and other challenges. We're looking at homelessness, mental health, alcohol and other drugs. If we can tap into those services like we just heard, if we can engage with people to give them opportunities to quit smoking, to be aware of prevention and cessation efforts, then we'll be taking a step in the right direction. I think particularly with the population groups I work with, we hear too often about everyday stresses. We know Aboriginal people have much higher rates of everyday stresses, racism, discrimination, a whole range of things that have challenged Aboriginal people over time. So I think we need to acknowledge that and look at addressing that moving forward. And some of these challenges aren't necessarily just tobacco related. I think if we look at public health more broadly, we know that things like racism and other things have poor health effects. We look at mental health and so on. So I think we need to also acknowledge the role that plays. Got justice reinvestment up there. I think trying to prevent people ending up in the justice system is incredibly important. I'd encourage you all to have a look into how we can perhaps remove money from the cure and start to put it into prevention in a whole range of things, including justice as well as health and so on, is incredibly important. I think education, we know that there's a strong evidence base around education. We can't underestimate that, and we need to continue moving forward with that. Tobacco-related morbidity and mortality, if we think about 25, 30 years' time, if we're looking at smoking rates around 42% today, we're going to be looking at tobacco-related morbidity and mortality that's sort of peaking in these marginalised populations. And I think it's really important not to be distracted by that. We need to focus our efforts and make sure we're starting to upskill and accelerate some of the efforts that we're putting into tobacco control. So a couple of cartoons there. One is basically to suggest that we shouldn't be distracted by things like tobacco industry research centres and so on. Kind of brought a smile to my face. The other one was a prescription for prevention. Again, I sort of spoke about the importance of prevention, the importance of youth. I think we all know that it's probably a lot easier to prevent someone from taking up than it is to get someone to quit. It is an incredibly hard addiction to kick, and we need to acknowledge that. So we've heard a little bit over the last couple of days about licensing, limited availability, prescription nicotine, perhaps having a licensing system for smokers where they can only access tobacco from a chemist or something like that. Age restrictions, perhaps raising the age to 25 years, perhaps not being able to buy tobacco if you're born after the year 2000. I'd be interested to see what sort of NRT products are available in 25 years' time. We're seeing things like e-cigarettes and so on come out, and I wonder what sort of regulations we'll have moving forward. We also heard a lot of people talking about vector regulation. How can we restrict these products? How can we regulate them? We heard about denicotinised cigarettes. And nicotine detox, that's one of the things that seems to come up consistently with the populations I'm working in. We have detox for a whole range of things. Is that something we can look into moving forward? And self-imposed smoke-free communities. It wouldn't surprise me if they're not too far distant future. We have smoke-free communities, we have self-imposed dry communities and so on. And so I wouldn't be surprised if empowered and done so correctly that some communities will opt to go smoke-free. Leadership. I think this one's a really important one. I think Australia generally has punched well above its weight in terms of tobacco control. We have some great leaders in the room, and we'll have some future leaders moving forward that are incredibly, insightful and exciting. And so I guess I'd like to see our role as tobacco control professionals moving forward, pushing the envelope and challenging ourselves to make sure that we play a good leadership role, both locally, regionally, nationally and internationally. How do we help everyone that's been represented here over the last couple of days in developing countries and developed countries to make sure tobacco isn't an issue? And last but not least, I guess the conclusion is there is no silver bullet. How do we make sure that we implement a raft of strategies to address tobacco? Should we be implementing things, complementing each other and implementing them regularly over time To finish, and I think this is nothing new, but we do need a comprehensive approach. We need to make sure we evaluate it and have strong evidence so that we continue to move forward and address tobacco. Thanks very much.
So now we're going to open it up to a panel.
I'm looking forward to hearing all of your questions. So have I got anyone on the floor?
Interested in the projection technology.
So you've got a question for our epidemiologist, Tabby?
I have, yes,
Right.
absolutely, because I get very frustrated by the limitations of projection methodology. It seems to me that we might usefully spend some time getting a more sophisticated model of the dynamics of the epidemic. You know, we talk about quitters and relapsers and continuing smokers and people who are taking it up and so on, and how that contributes to prevalence. But I think we ought to be able to cut and dice that a lot more by target groups. Can we get a more sophisticated model of the tobacco epidemic that allow us to weigh up different measures in relation to their aggregate impact?
I think what you're suggesting is that you want a more complicated model. And basically the more things you add into a model, the more assumptions you're making. And if you want to try and project those assumptions out into the future, it just becomes unstable.
Yeah, I'll give you the economist answer. Economists have been trying to develop those more complicated models and taking account of what we know about the relative impacts of different policies on different populations. So I think some of the work that David Mendez and Ken Warner have been doing together on their projection modeling is really nice and does allow you to sort of tease out if you were to really get big reductions in initiation in this group, what would that do? Or cessation in that group, what would that do? So the modeling is getting there. There are obviously a lot of assumptions, but economists don't shy away from making assumptions.
Thank you.
Andrew Prusco from the Commonwealth Department of Health. And just to say, Kylie, you got my heart racing with your presentation, but I'm still here. There's no ambulance. You have to be bolder. Just wanted to ask, with the end game scenario for Australia, what role do you think maybe extending the work we've done with 5.3, Article 5.3 under the FCTC? It seems to me that if we want to get to an end game, that we'd probably have to implement that further in Australia and make sure that we remove the influence of the tobacco industry in the political process. So just your thoughts about how we could do that.
Sure, and yeah, for those people that aren't familiar with the FCTC, Article 5.3 is about making sure that the tobacco industry can't interfere with public health policy. And you're right, Andrew, I guess we haven't, the guidelines for Article 5.3 say that countries should have some sort of policy and system in place for how you engage with the tobacco industry. I think Australia's fairly lucky in that we've had some fairly good systems, or successive governments haven't been too willing to engage too much with the industry, but we can certainly improve that. Things like political donations, disclosing meetings, what's going on. So I agree. I think we could do better there. I think we could have a more structured policy, and it's certainly something that should be in the mix. And I absolutely know that for our colleagues in the Pacific Islands in particular, this is an enormous problem and something that they struggle with endlessly and is causing them issues in terms of progressing tobacco control, and we should be helping them, but also, that they're trying to deal with this as we speak.
Hi, Maya Rivers from Vic Health. Sarah, I like the way you say we've got to change the way we're talking about things. I think reframing things is important. And I know something we're trying to do at Vic Health, and we have a whole social determinants of health theory that we try to follow, is instead of calling people smokers, they are people who smoke. It's a bit like calling me freckle face, but I'm a person with freckles. So I think we should be quite sympathetic in that regard. I've sat in the session before about mental health, very focused on the treatment setting, and I wonder whether we need to be asking why people with mental illness are smoking in the first place. Because getting them to quit is so hard. Should we explore further or more intensely why they start to smoke in the first place? And really that probably leads to social determinants of health because of all those things that influence the way they smoke. But I'd be keen to hear your thoughts on, the panel's thoughts on some of that.
Why do people smoke if they've got mental illness? Yeah, okay, that's the huge question. But I guess the point that you're making, or the question you're asking is, can we actually touch people in systems before they get there? And I think the answer is yes. So we've got opportunities to reach people in the education system. We've got opportunities to reach them in the community mental health settings, GP point where they pass into perhaps an acute clinical setting, and then when they come back out. And that's, I think it's really important to have very consistent approach so that people are hearing the same supportive, reassuring, you can do it, all the right things at every single point that they have. And just it's creating a great big safety net that's going to catch them when they're ready to try and make the quit attempt. And so that'd be the point I make on that. And the messaging, I think our language, I hope our language is actually going to change. And again, I'm a newbie to this field, but I come from a comms background, and I think as soon as you start talking about smoking as a behaviour, activity, habit, choice, whatever you want to call it, you put it on a values, it's a values base. So I think we have to take it away from that to start reaching people.
And then just on the issue of mental health and smoking, I think it's probably a more complicated picture than we realize, and I think there is evidence emerging that suggests that smoking actually causes some of the mental health problems. So it's not sort of this one-way street, and I think that, again, some of them, the interventions that we know work to reduce smoking may actually help reduce smoking in the mentally ill population. Yeah.
Kristen Carson from the University of Adelaide. I've actually got one question, but for each of you to answer. If you had to guesstimate when you think Australia could be smoke-free, by what date, when do you think that date would be?
Yeah, I'm afraid I'm not really sure. I would have to run the projection and see when that line hits the zero.
Look, it's totally dependent on what we do to get there. And, you know, if we had the absolute political will and all the resources that we needed to do it, we could do it very, very quickly. But there are realities that come into it. So, you know, I'd love to say that in 5 years' time I would have no job and I could retire to the beach. That'd be great.
What she said.
Yeah, given the way things have gone, given the sort of innovative approaches that have been taken here, 2035 maybe? And smoke, you know, less than 5%. Maybe I'm not optimistic enough, but...
I'll shoot a bit earlier than that. I'll say 2020. There we go.
Whoa. So, Raglan, can I put you on the spot there to finish off our session? Out of everything you've heard, what will get us there? What are you thinking? Or is it? I know it's a combination of things, but what stands out to you at this stage?
So when I said 2020, I guess there's obviously a lot of dependent variables that we could throw in the mix. That's my caveat. Again, I think we've heard actually a whole range of really good ideas. I'd like to see them all implemented in various ways. I think if we can continue to build the evidence and move forward and hopefully build on the ideas that we've come up with, I'm sure we can strengthen them as we progress. So again, no silver bullet. I'll just say we'd like to implement them all as we go.
Great, thank you, Regan. I think that's a really good note to finish off on. And I think as we're moving forward, it's really important to note that everyone holds a crucial piece of the tobacco control jigsaw, and no one person or one organisation owns this journey. So we look forward to working with you now and into the future. And thank you.